working there. I am still working there, but she has moved to greener pastures and higher pastures. That is good. So I hand over the mic to Dr. Jasmine for today's session.
Good afternoon, sir. Good afternoon, everyone. And thank you for the kind introduction. And I say my medical knowledge. I've been born and was brought up in Lady Hardinge Medical College. And thank you for my mentors for bringing me to the stage that I'm at today. So I'll start with my talk, which is about epilepsy, its diagnosis and management. So we get into the details of today's topic. I would I would like to talk about like what is the difference between a seizure and epilepsy. So not every seizure translates into epilepsy. So seizure is just the clinical symptom that the patient has because of some abnormality or some abnormal activity, electrical activity that happens in the brain, and that leads to some clinical symptom which may happen. But not every seizure translates into epilepsy, because there are seizures that might happen just once in life because of acute insult. And then in epilepsy, epilepsy is a disorder in which the patient has a recurrent predisposition to seizure. So seizure may happen once, or it may happen multiple times, or the patient may have a repeated predisposition to have seizures. And when he has predisposition to have repeated seizures, that becomes epilepsy. So today's talk will at the end of the talk we should know how are we going to diagnose epilepsy, how are we going to investigate, and how are we going to manage epilepsy. Before we get into that, we let's take a few case scenarios, because these will be the real time presentations or the real clinical presentations that you will see for your patients, and the management would differ for each of them. In the first case, we have a 65-year-old woman who has history of hypertension, chronic kidney disease, and she presents with recurrent episodes of confusion and generalized seizures and altered sensorium. During each episodes, the patient has been documented to have a sodium level which is less than the normal range, like in 115 to 125. She has been admitted multiple times in the past year with the similar presentations, and often she has used diuretics for her primary disease, which is CKD. And in between the periods of these seizures, she has been absolutely normal. And when we got the EEG done, the patient during the post-ictal state, she had generalized slowing but did not have any epileptiform discharges, and MRI brain was normal. So this is the first scenario that we have. We'll come back to these scenarios and we'll look into the details of this. In the second case, we have a 28-year-old man who presents with single episode of focal onset seizure with secondary generalization and has no prior neurological symptom. Now, MRI brain reveals solitary, well-defined calcified lesion in the right parietal cortex with the minimal surrounding edema, and the EEG in this patient is normal. And now we have the third scenario, in which we have a 22-year-old male with no prior medical history presents with a single episode of generalized seizure. Over the past several months, he has noticed brief involuntary jerks, which comes to the myoclonic jerks, and they happen mostly in the morning hours, where the patient drops objects like toothbrush. And EEG when done in the interictal period is completely normal, and the MRI brain of this patient is also normal. So we'll come back to these scenarios shortly. Before that, let's know that what is like epilepsy and how do we diagnose. So, according to International League Against Epilepsy 2014, which is the latest definition of epilepsy, epilepsy is a disease of brain which is defined by any of the following conditions. If the patient is having at least two unprovoked seizures occurring more than 24 hours apart. Unprovoked means that there should be no immediate inciting factor, and we will talk about the provoked seizures. So they should be unprovoked seizures, more two episodes more than 24 hours apart, or the patient may have only one unprovoked seizures, and the probability of having the further seizure is similar to general recurrence risk, that is more than 60% after two unprovoked seizures. So if one seizures and the recurrence rate is likely to be more than 60% based on all the other investigations that we do, like EEG or MRI, or we look at the other clinical scenarios. Then third is if we have diagnosed the patient with an epilepsy syndrome. If among these any of the criteria is satisfied, the patient fulfills the definition of epilepsy that mandates the patient getting anti-seizure medicines for his treatment. So now let's go back to the scenarios that we had. So in the case one, we had this patient who had chronic kidney disease and he had hyponatremia. So this looks like an acute symptomatic seizure. Although he had 3 episodes, but every time he has been documented to have hyponatremia. So these are three provoked seizures because of hyponatremia. So this does not fulfill the definition of epilepsy. So this patient doesn't get anti-seizure medicine. Then we come to the second case scenario. In this, the patient has a focal seizure, but in the MRI, we see that there is a calcified lesion. And this calcified lesion points to the site, he's having focal seizure. Probably, if the site also corroborates with the focal onset of the seizure, in that case, the MRI tells us that this patient may again have seizures because the clinical semiology of the seizure and the MRI are correlating. So in this case, the probability of him having another seizure is very high. Now, we cannot predict exactly whether it is more than 60%, but if your clinical acumen says that it is likely to be more than 60%, then this patient also fulfills the definition of epilepsy. But here is a caveat, like this, I have said that the patient has a solitary, well-defined calcified granuloma, so which is generally a neurocysticercosis in our cases. In patients who have a cyst and there is surrounding edema, this seizure could also represent an acute symptomatic seizure. But now this patient is having a calcified lesion. So this lesion is less likely to dissolve. So in this patient, I would consider that this patient is more likely to have chances of another seizure in future. So that is why I would consider this patient having epilepsy rather than just an acute symptomatic seizure. Now, in the third episode, I said that this patient has generalized seizure and he has history to suggest myoclonic jerks. If you look at the clinical scenario, he's having myoclonic jerks in the early morning hours, and he's a young male, 22-year-old. So this definition fulfills the criteria of juvenile myoclonic epilepsy. And when you diagnose epilepsy syndrome, so juvenile myoclonic epilepsy is an epilepsy syndrome. So once you diagnose a syndrome, that means the patient fulfills the criteria of having epilepsy and requires treatment. So the 3 scenarios corresponded to the 3 conditions that we have seen. So now, whenever we diagnose the patient having seizure or epilepsy, the diagnosis is primarily based on the history. So if you do a CT scan of a patient for maybe headache and you find a calcified granuloma, this doesn't mean that the patient is having epilepsy. If the patient doesn't say that he clinically have ever had a seizure, you cannot diagnose epilepsy or seizure on the basis of imaging. So that means it is mainly a clinical diagnosis. It is based on the history that you get. Every time you see a patient with epilepsy, and you always have to rule out whether you are dealing with mimics or not. For example, in elderly patient, we have to rule out syncopal attacks. We have to look for psychogenic non-epileptic seizures, which are now known as functional seizure disorder. And then you have to rule out a provoked seizure. So you get all the investigations done, like blood investigations done, look for the history of any fever, high grade fever, or anything to suggest brain infection that can cause seizure. In those cases, that is a provoked seizure. Then whenever you have found out that it is a seizure, you need to find out whether it is a focal or a generalized seizure, because your management will depend on that. And then you don't stop there, you find out the etiology of the seizure. Sometimes it is a secondary thing, it happens secondary to something. Maybe the patient is having a focal cortical dysplasia, so that can tell you that in the long term the patient is likely to have seizures which might turn drug resistant. So you have to take a call accordingly and you have to do the counseling accordingly. Sometimes the patient may have a medial temporal sclerosis, so similarly you have to take a call accordingly. Now, what are provoked seizures? We have repeatedly talked about unprovoked seizures that in the diagnosis of epilepsy. So, to know what is a provoked seizure is important, because everything which is not provoked is unprovoked seizure. A seizure that happens within 7 days of acute brain insult. For example, within 7 days of having a stroke or traumatic brain injury or a brain surgery, or when the patient is having active meningitis whole during that period and then 7 days plus minus. If the patient is having encephalitis during that period and 7 days plus minus, then you call this patient having provoked seizure. If the patient is having a seizure within 24 hours of a metabolic derangement like hypoglycemia, hyponatremia, uremia, and other things, or drug intoxication, or even the patient who has a drug withdrawal seizures, all those are classified under metabolic derangements and are provoked seizure, not mandating anti-seizure medicines for long term. And if the patient is having drug or alcohol intoxication or even withdrawal, as we've talked. Now, there are few scenarios that may lead to an acute symptomatic seizure or a provoked seizure and may lead to epilepsy also. Now, these are not the only conditions, but this is just for the examples that I'm going to tell you that, for example, a patient who presents with autoimmune encephalitis. These patients with autoimmune encephalitis, if you look at the diagnostic criteria, they generally present with new onset seizures. So they have recurrent seizures, but the definition never mentioned new onset epilepsy because they are all in the inflammatory phase of the disease when the patient keep on having seizures and may present with status epilepticus or refractory status epilepticus or super refractory status epilepticus. So they, even when they are having status epilepticus, it doesn't qualify to be epilepsy because it is happening in the acute symptomatic stage of the acute encephalitis. However, when the acute inflammation has subsided, or if the patient is in the sequelae phase, or if the patient has improved and after that the patient start having epilepsy because of the lesions that are left or have damaged the brain permanently, then it qualifies to be epilepsy. So a same disease in the acute phase can cause acute symptomatic seizure, but however, if the patient continues to have seizure even after the acute phase has subsided, will lead to epilepsy. Similarly, for head injury, within 7 days of head injury, if you have, then it is acute symptomatic. But if the head injury leaves a brain scar which is throwing seizures in later part of the patient's life, it becomes epilepsy. Similarly, for stroke, if it is happening within 7 days of stroke, it is acute symptomatic seizure. However, the damage to the brain that has happened because of stroke leading to further seizures in life will lead to epilepsy. So the classification of epilepsy keeps on changing from time to time, but this is for but the practically it doesn't change much the management perspective of the patient. But as we have to follow, we have to know what ILA says. Last in 2017, since the time I have started my medical practice, this is the fourth classification of seizures and epilepsy that I'm seeing. So this is in 2017 we had the last classification in which we divided the seizures into. This is the classification of seizures. So classification of seizure was into focal onset, generalized onset, or unknown onset. And the focal onset was further divided into aware or impaired awareness, and then according to the semiology it was divided into motor onset or non-motor onset. Similarly, the generalized onset was divided into motor onset and non-motor onset, and unknown onset again divided into motor or non-motor. And if the patient did not, if you do not have too much knowledge about the patient's clinical scenario, whether it is actually a seizure or not, you just leave it as unclassified, maybe to be classified later when you get more information. But in the 2024 classification, they have removed the term onset. This is because they want to say that at the onset, sometimes, like, you might not find a thing that may point to focality, but maybe in the middle part of the seizure you get one side involved more than other. So the onset is not only important, whole of the seizure is important. Like throughout the seizure, it is the whole of the chronology of the seizure is important. So it is described as a chronological sequence of semiology, not just based on the onset. That is why they have removed onset from the definitions of the seizures now. And the second thing that they have changed is that they have replaced the term just aware and impaired awareness with consciousness. So consciousness is a part where you look at the patient's, not just patient's awareness, but also the patient's responsiveness. So the combination of these two is consciousness, which have been used in the current classification of 2024. Other things remains the same. So we had talked that whether the patient is having seizure or not, epilepsy or not, or seizure or not, and then we have rule out mimics. And once we found out that the patient is having seizure, we have to find out whether the patient is having focal onset or not. If we are very clear and we know that whether it is focal onset, then we say it's focal onset. If we very clearly know that the onset is generalized, we say generalized. If we don't know what it is, then we call it unknown onset. So what are the very clear predictors that says that this seizure is a focal seizure? So if the patient has clear focal, motor, or sensory phenomena, like I'm having tingling in the right hand when my seizure is starting, so I have a clear sensory phenomena, or the relative says that the patient, he saw the patient having the left upper limb movement to start with, and then the whole of the seizure progress. So you know that it is a focal motor seizure. Sometimes these things are not very clear and you have to ask, like, does the patient have any aura? क्या आपको पता चल जाता है दौरा आने से पहले कि आपको दौरा आने वाला है, और आप खुद को alert कर लेते हैं, and you go and sit at a place, like, you can make yourself safe, that now you're going to have seizure. So this might not happen in the first seizure or second seizure. It is after a few seizures that the patient comes to know that every time he has seizure, he has this phenomena. It might be a visual phenomena which you won't see, the relatives won't see, only the patient would know. It might be an epigastric rising sensation ki kuch gola sa पेट से उठता है. So let the patient describe their seizure, let them talk first, and then maybe we can ask them the questions that we have, the answers we have not got yet. Then aura is the second thing. Third is automatism. When the seizure happens, they have, like, some picking movements, or there is one hand may be engaged in the seizure, other hand they are picking something, or they are just having some hand movements which is stereotyped, or they may be just wiping their nose, or look, just touching their face. But repeatedly, if in all the seizures they are having such movements, it is likely that it is an automatism, and then it also suggests a focal seizure. If the patient is having weakness of one side of the body or one limb after the seizure, it also suggests that the seizure was a focal seizure. So these are very, very clear signs that the patient is having a focal seizure. And other things we can make out from the history or looking at the video. So ask your patients to make home videos of the seizure, so that you can find out whether it is a focal or a generalized one. So the diagnosis, as I told, is mainly clinical. We had a study conducted at our center in which we saw 512 patients with epilepsy, and two of the investigators were looking at the clinical semiology of the seizure and diagnosed this patient as having either focal seizure or generalized seizures. So when EEG or neuroimaging were added to this clinical information, the change in the diagnosis was only in 3.2% of the patients, suggesting that most of the patients got their diagnosis as focal or generalized based only on the clinical history. So we talked about the classification of seizures. Now we come to the classification of epilepsy. So classification of epilepsy is just like the classification of seizures. So if the seizure is, first of all, we classify the seizure type, whether it is focal, generalized, or unknown. And then we combine them and classify them as epilepsy, whether the epilepsy is focal onset, generalized onset, or unknown onset. Sometimes we may have seizures in which we have both the types of epilepsy, like we have Lennox-Gastaut syndrome, where we can have generalized seizures also and focal seizure also. So it can be epilepsy type where we have combined generalized and focal. And then we look at the etiology of the seizures during our workup, and we look at the comorbidity, and we make a syndrome out of it, which is known as the epilepsy syndrome. For example, we look at, for example, the patient comes with a seizure which is a focal seizure and have a temporal lobe semiology, and then we will classify the seizure as temporal lobe focal seizure, and then we will classify the epilepsy as focal temporal lobe epilepsy. And now we look at the MRI and we find that there is a structural lesion in the temporal lobe. So in etiology, we have found that there is structural lesion. For example, this structural lesion is a medial temporal sclerosis. Now we have made a diagnosis of medial temporal sclerosis leading to temporal lobe epilepsy as the syndrome. So this is how we reach to the epilepsy syndrome diagnosis, and we should make all the attempts to reach that syndrome diagnosis and not just leave it at the seizure type diagnosis, because it helps us prognosticate. Now that I have reached to a diagnosis that the patient is having epilepsy because of medial temporal sclerosis, and I know from my literature review that this is likely to have a drug resistant epilepsy and might require surgery, so it will be easier for me to counsel the patient. It will be easier for me to follow up. I can tell her to come after 6 months or now come after 2 months. I can predict that whether she will have response to one anti-seizure medicine or she might require multiple anti-seizure medicines. Now I have diagnosed my patient as having epilepsy. Now I need to investigate the patient to find out what cause the patient is having for her epilepsy. But not just epilepsy, for the seizure type. That is what that our goals of investigations or the investigations that we are going to order depends on what scenario the patient has presented to us with. Whether the patient has presented to us with acute seizure for the first ever seizure in the emergency, or the patient has subacute onset seizure, or the patient is having seizures for the past few months or maybe a day, maybe few days. That is second scenario. Third is that the patient is having seizures for the past 10 years on and off, happens once in a while. It is a drug responsive epilepsy, which is a chronic epilepsy. Or the patient has epilepsy for the past 10 years and has come to you after 10 years with seizures happening like every day, or maybe 10 times a day. It is a drug refractory chronic epilepsy. Or the patient has come despite having any of these scenarios in status epilepticus. He may come with first time status epilepticus, he may come with a chronic epilepsy which was drug responsive and now coming as status epilepticus, or it is a chronic drug refractory epilepsy now coming as status epilepticus. So your investigations will depend on what scenario your patient has presented to you with. So we will briefly discuss about the investigations now. As I know, like all of you are physicians, so according to the scenarios, all the blood investigations will be carried out as a part of the workup. But we will talk primarily about the epilepsy directed investigation. So let us talk about the neuroimaging. So neuroimaging, according to International League Against Epilepsy, MRI is the investigation of choice. But we stay in scenarios where MRI might not be possible. So we'll talk about the Indian scenario also. But let us first talk about the MRI. Who should have an MRI? And what are the minimum requirements when we order an MRI for a patient? That is what does epilepsy protocol say? So in this, the neuroimaging task force of ILAE advises harness MRI protocol. It should be done as soon as the patient have first seizure. That even after the first seizure, they want harness MRI protocol to be done, and this will establish the syndromic definition and guiding management. However, although this is the recommendation, the practice recommendation, and also the recommendation by ILAs, if the patient is presenting with first seizure, rather than directly going for MRI, we should get a CT scan done in the emergency. This is because many of the conditions, many of the medical emergencies in neurology and neurosurgery may present with seizure for the first time. And all the newly diagnosed epilepsy patients as well as the chronic epilepsy patients should also get a harness protocol MRI done, and all the drug resistant epilepsy obviously should get harness protocol MRI done. However, if the patient is already having an established epilepsy, for example, you are following up a patient with epilepsy for the past 10 years, and now the patient comes with another seizure to the emergency, that doesn't mandate any brain imaging at all. So do not repeat a brain imaging if it is the same scenario that is happening again and again to the patient, unless there is some red flag to suggest an additional damage to the brain or an additional presentation as a status epilepticus. In that case, we can repeat the brain imaging, otherwise it is not required. So what is the harness protocol of MRI that we have been talking about? So it is harmonized neuroimaging and structural seizure lesions. So this is basically to standardize the imaging protocol so that all the patients with epilepsy get a uniform imaging protocol that increases the lesion detection rate. So the standard MRI, stroke demands a different form of MRI images that are very important. You can just do diffusion and flare, and that is all that you might require. But if you have another disease that the patient has epilepsy, we need to look very clearly into all the areas of the brain, and we need to see even subtle gray white differentiation loss which might be epileptogenic, or we might have to see subtle change in the temporal lobe volume of the two sides, which may say that one of the side is abnormal and causing seizures. So it is very important that we define the protocol so that all these small things are picked up. So the harness protocol says that you get three types of imaging sequences done, that is T1 weighted, T2 weighted, and flare. So T1 and flare is 3D. So there is nothing to define that what plane it is to be done, because if you do it in a 3D mode, then you will have all the three planes ready for themselves, that is sagittal, axial, and coronal. So 3D imaging T1 and flare, but T2 protocol has to be done mainly coronal T2, and the axis of this T2 has to be perpendicular to the hippocampal long axis. Uh, if you can see my marker, can you see my marker? Can you see the arrow that I'm pointing? Can anyone tell me if the arrow can be seen? Okay. So if you look at the the sagittal image in the first part, in the first half, the last image, so you see the temporal lobe there, and if you draw axis here, the coronal image have to be perpendicular to it. I did not get any response, so I'm not sure if you have been able to make it. But I just want to say that the acquisition of the coronal image has to be perpendicular to the long axis of the hippocampus. So in the first seizure, if the patient presents to the emergency, there can be a multitude of causes that the patient can have. It might be a cerebrovascular disease, that is stroke, or it can be head trauma. It can be a brain infection like tubercular meningitis or a tuberculoma like there, or it could be a metabolic cause or a toxic cause. So you can see here that a cerebrovascular disease or head trauma or CNS infection may be picked up by CT scan. So doing a CT scan in the first seizure is very well justified. Sorry. So as I talked that in the chronic epilepsies which are drug responsive, a CT might do. So we don't need to repeat the imaging. But if the that is a very very common clinical scenario with in Indian population. If you go to the villages and you see the patients who have been having epilepsy for a very very long time, and it is either drug responsive or maybe they have not tried drugs, but you do not expect to find a large lesion that you're going to remove in the first go. So in such cases where you have drug responsive focal epilepsy, a NCCT may suffice. This we have done a study at our center where we had almost 200 plus cases of focal or unknown onset epilepsy, and we got a contrast CT as well as non-contrast CT done, and we found that the non-contrast CT have very high sensitivity and specificity, and when compared to the contrast CT, and there was no change in the management of the patient based on the imaging finding that were detected on the contrast CT. And most common lesions that we detected in this drug responsive focal epilepsy patients in our center were the calcified granuloma. So that also suggests that the CT might suffice in most of our cases of drug responsive chronic epilepsy. Now come to the next investigation, which is EEG brain. So basically, EEG brain will detect the seizure activity. It might diagnose some of the epilepsy syndrome, like in JME, you might get polyspike and wave discharges, or it may help us rule out the seizure mimics, like the patient is having active seizure but you don't get anything in brain imaging, although a rare possibility is that the lesion is lying very low. But if the patient has started having generalized seizure and still the EEG is normal, that means it is likely a non epileptic seizure. If you want to do a EEG for a patient and you give a date after 6 months of the seizure, it is of no use. Get the EEG done within 16 hours of the seizure to increase the yield of the EEG. I know that is not very much possible, even we give long dates, but that is the best time to pick up the epileptiform discharges if you do EEG within 16 hours of the seizure. Normally, EEG doesn't rule out the seizure, and if the EEG is negative, you might have to repeat it, and EEG may also be negative if the seizure focus is very deep seated. That means a positive EEG finding is conclusive, but a negative EEG finding is not conclusive. Now, if the patient has drug resistant epilepsy, now what is drug resistant epilepsy? First, let us see what is drug resistant epilepsy. Okay, I'll come to that. I think it is in another slide. So we'll come to the definition of drug resistant epilepsy later. But if you diagnose the patient as having drug resistant epilepsy, you have to do extracranial long-term EEG monitoring. You have to do an MRI. You might have to do, depending on your concordance of the imaging, clinical, and EEG finding. If they are all concordant, if they are all localizing to one site, then you are happy. If they are not localizing to one site, or if the MRI is normal, then you have to do a lot of other investigations like PET scan, SysCom, that is SPECT, fMRI, neuropsychological assessment, or MEG, and many other multimodalities that have come for the evaluation of drug resistant epilepsy. But that maybe we can discuss in some other lecture some other day. So now let's come to the medical management. So medical management is dependent on anti-seizure medicines, and anti-seizure medicines, when to start the anti-seizure medicine. Anti-seizure medicines should be started in all the patients when you have reached the diagnosis of epilepsy. Remember, we had talked about the diagnosis of epilepsy, the criteria, the three scenarios. So according to those scenarios, if the patient has been diagnosed as having epilepsy, even after a single seizure, or diagnosis of epilepsy syndrome, or diagnosis of two unprovoked seizures 24 hours apart, you must start the patient on anti-seizure medicines. Choice of anti-seizure medicines we'll discuss later. If the patient presents with a single seizure, now this can be a shared decision making. You have to tell the patient फॉर एग्जाम्पल लाइक आई टॉक टू माई पेशेंट्स लाइक आपको एक दौरा पड़ा है, आपको जिंदगी में दूसरा दौरा आने का भी चांस है, ये दौरा आने का चांस आपको उस मरीज से कम है जिसको जिंदगी में कभी दौरा नहीं आया. सो दे ऑलवेज हैव अ चांस ऑफ हैविंग अनदर सीजर मोर देन अ पर्सन हु नेवर हैड अ सीजर इन लाइफ. Now given this, do you want to start anti-seizure medicines or not? So shared decision making is too much into practice now, but if it is a provoked seizure, then you don't start. If it is an unprovoked seizure, then but single unprovoked seizure, it is good that you discuss with the patient and the family members, because starting anti-seizure medicine does not give 100% proof against another seizure, and not starting it, it leads to it might give them just a risk of having another seizure, and all the time they having a mental burden of having another seizure. So you have to discuss with the patient and the family. Now, it also depends on the patient's profession. For example, if the patient is staying in hostel, is staying alone, you might want to add anti-seizure medicine. If the patient, uh, despite repeated counseling, the patient is driving, you might have to start anti-seizure medicine. If the patient is having employment where he might have to do night duties and he just cannot, skip doing it. For example, he is the only bread earner and doing night duties as a guard, and he says that he just cannot leave it. Then you don't wait for second seizure to start anti-seizure medicine, you start them the anti-seizure medicine. So it depends on the clinical scenario also. But overall, if the first seizure has happened, unprovoked seizure has happened, there is a study that tells us there are multiple studies, and out of those studies we have got some recommendations or guidelines that tell us that there might be another chances of another seizure, which are very high if the patient have had prior brain insult, even if it is not associated with any brain imaging abnormality. If the patient's EEG shows some epileptiform discharges, if the patient have a significant brain imaging abnormality, and if the patient have the first seizure as the nocturnal seizures, the chances of having recurrence of seizure is high, and these patients mandate starting the anti-seizure medicines. Now, what to start? It depends on the seizure type. So here is a chart. Basically, the general practice is if the patient has the first seizure as the seizure or epilepsy as a focal, then carbamazepine, oxcarbazepine are good options. If the first seizure is a generalized, then levetiracetam is also a good option. Lamotrigine is also a good option. Phenytoin, valproic acid are generally going out of fashion because of the side effects, and now we have drugs that have very less side effects, so we try to choose them. So depending on the seizure semiology, you can check the anti-seizure medicine chart, and then you can start them. Now, when to step up, like you have started the patient on first anti-seizure medicine, and you see that the patient is not having a response and patient has come to you. First of all, you check that have you used the drug in appropriate dose. A patient who weighs 80 kg and you have used levetiracetam 500 mg BD is not going to have a good response. The patient is likely because the drug is not in the optimum dose. So you have to maybe try to go up to maximum dose if the patient has responded to some extent, but maybe there are some seizures which are not responding. But if the patient have had zero response, you might consider switching the drug or maybe adding on another drug. So poor response is one indication. Second is side effects. I gave levetiracetam to the patient, is having a lot of psychiatric side effect. I will have to change the anti-seizure medicine or add something else. So, what drug should be chosen when you add on? What is the second drug that you choose, or what is the third drug that you choose? So, the general principle is, so I'm not going to read out this table. This table is given in many books, and Harrison has very beautifully written the chapter on epilepsy. You can all go through that. I still refer to Harrison for too many of my neurology topics. So the principle is that you choose anti-seizure medicine from a different group. Like if you have started using sodium channel blocker, you try to use a calcium channel blocker when you add on another drug. So just try a different group if the anti-seizure medicine of one group has not worked, or it will be easier. The patient will have lesser side effects also, and there will be more efficacy. And you can just check the doses, and whenever you start anti-seizure medicine to a patient, you can just revise the list of side effects, and you can also tell the patient that these are likely the side effects and they should be alert and come back. And at times you might have to write on the card, watch for rash. For example, if you're starting lamotrigine, you have to categorically tell them that you watch for rash. If you develop rash, stop this medicine, come back, we will change the medicine. If you give carbamazepine, similar thing has to be told. If you're giving clobazam, you have to tell them that you don't have to take it in the morning hours. Take all the dose, even if it is 20 mg. Take it at night. Take it at 8 p.m. Do not take it at 11 p.m. so that you have sleepiness the next morning also. So take it at 8 p.m. so that all the sleepiness side effects. So you have to, according to the drug you give, according to the side effect profile of the drug, you have to counsel the patient. Now, some special scenarios. Women of childbearing age group, you have to avoid valproate and carbamazepine due to teratogenicity. Preferably give lamotrigine or levetiracetam, and always supplement with folic acid. And for the elderly, since they are more likely to have side effects of the drug, so you have to start with a lower dose and you have to slowly hike the dose up, and prefer the drugs which have lesser interactions, like lamotrigine and levetiracetam. Avoid the drugs which can have enzyme inducing or enzyme inhibiting interactions. If the patient has special type of juvenile special types of syndrome like JME, then the drug of choice is valproate. For example, a female comes to you in a reproductive age group and has JME, you do not start valproate, you switch to another drug like lamotrigine and levetiracetam. So the clinical scenario changes. Like, always we have been taught that valproate is the drug of choice for JME, but your clinical scenario changes, then your choice of drug changes. In the pediatric patients, there may be some specific syndromes which are responsive to certain types of anti-seizure medicines, which we don't which the adult neurologists or adult physicians do not use, like ACTH or steroids for infantile spasms. Then till when should we continue the drugs, and when should we stop the anti-seizure medicines? So basically we can consider stopping or tapering. I would not say rather stopping. We should taper and then stop anti-seizure medicine if the patient has been seizure free for 3 to 5 years with low relapse risk. For example, if the patient has focal cortical dysplasia, you cannot think of tapering the medicines, because once you taper the medicine, the patient is definitely going to have, because there is an epileptogenic focus which is always present in his brain. So you don't taper. So your scenario changes. Even if the patient has been seizure free for 5 years, you don't stop. But if the patient has had a normal brain MRI, has just had one seizure or maybe two seizures 2 months apart, and now he has been seizure free for 5 years, you can take that risk. But whenever you taper and stop the anti-seizure medicines, you have to tell them the risk of having another seizure in life, the way we talked earlier, that it may again happen and you might have to restart anti-seizure medicines. So if the patient had failed withdrawal once, I prefer generally not to attempt another withdrawal. Like, if 10 years back he had tried withdrawing the medications, but he started having seizures again, and now he's again seizure free for 5 years, I don't attempt another withdrawal. I just tell them, take safer medicine, but take for life rather than having another seizure again. And you have to gradually taper over 3 to 6 months. And when do we say that the patient has remission and he is epilepsy free? Although the risk never becomes zero, but if the patient has been seizure free for 10 years and out of these last 5 years he has been off anti-seizure medicine, then you call the patient having seizure freedom or remission. Now the surgical management. We were to talk about drug resistant epilepsy. So all the patients who have drug resistant epilepsy are to be referred for epilepsy surgery. So epilepsy surgery is the treatment of choice for the patients with drug resistant epilepsy, and it can be life saving. According to International League Against Epilepsy, when the referral should be done for all the patients for epilepsy surgery if they have drug resistant epilepsy, even up to the age of 70 years, as soon as we have identified that that they have drug resistant. Like, we don't have to wait for 4 years, like, let me try one more drug, let me try one more, maybe ab, let me try 7 drugs, and then make the patient label drug resistant. No, after 2 drugs you label the patient drug resistant, and you refer them to the epilepsy center, comprehensive epilepsy center, for evaluation and maybe consideration of the surgery. So older adults with drug resistant epilepsy, like older than 70 years, if they do not have any contraindication, you refer them. If the patients who have been seizure free on 1 or 2 anti-seizure now that is what we have talked, that if the patient has drug resistant epilepsy, you definitely refer. But there are certain conditions where you don't wait the patient to turn drug resistant, because you know that there is a brain lesion, and if you don't take action, it might turn drug resistant in future. They are known as long term epilepsy associated tumors. Like, I have been talking about focal cortical dysplasia, uh, dysembryogenic neuroendocrine tumor, so DNET. So all these conditions, MTS, medial temporal sclerosis, these are likely to cause drug resistant epilepsy. So you refer them for evaluation of DRE in such cases. for pre-surgical evaluation, even if they have not turned drug resistant. However, if the patient has active substance abuse and he is not taking his medications, like he's missing his medications every time, he's getting seizures because he's missing his medications or not taking on time, these are not the ideal candidates for referral for for surgery. So what is drug resistant epilepsy that we have talked about? If we have a patient who has failed adequate trial of two tolerated, appropriately chosen and used anti-seizure medicines, either as monotherapy or in combination to attain sustained seizure freedom. That means that if I've taken levetiracetam, I did not get seizure free. I continued to have seizure. Or then my doctor added clobazam to me. I still continue to have seizure, and the seizure frequency might have decreased, but I have not attained a sustained seizure freedom. So even from 10 seizures in a year, now I have 3 seizures in a year, then also I am drug resistant. So now, before the my doctor adds the third anti-seizure medicine, the best decision that he should take for me is refer me to a expert where pre-surgical monitoring can be done, pre-surgical evaluation can be done, and I can be considered for epilepsy surgery. So, as I told that details of epilepsy surgery we cannot discuss in this class, but epilepsy surgery is not reserved only for patients who have one brain lesion, or who have brain lesions, or who have focal epilepsy. We can do epilepsy surgery even for the patients who have generalized epilepsies or who have epilepsy syndromes. So there are some forms like vagal nerve stimulation, deep brain stimulation, or corpus callosotomy, which can be carried out for the patients who have generalized epilepsy also. There is another thing which is known as responsive neurostimulation, but is not available in India, only available in USA. Now, management of comorbidities. As much as important that we manage the patient's epilepsy, it is important that we talk about the comorbidities and we tell how to comorbidities. Most important of comorbidities, that is depression. Mild depression, if the patient is having, just do cognitive behavioral therapy, and if needed, the patients may be given SSRI as the first choice. If the patient has moderate to severe depression, then SSRIs, and if there is inadequate response, we may add venlafaxine. Now, till how long should we consider the management of depression? After the first episode of depression, we may continue the treatment for more than equal to 6 months. But if the patient have had previously depression and then we stop the treatment, and this is the second time we are giving treatment for depression, then in this case, you have to consider the treatment for at least 9 months and maybe more, depending on the patient's severity of the symptoms or persistence of the residual symptoms. And preferably, when you choose the anti-seizure medicines in these patients, you're not going to choose levetiracetam, which is likely to exacerbate the depression. You choose the mood stabilizer or cognitive sparing profiles like lamotrigine or valproate or even carbamazepine. Then somatic comorbidities include migraine, sleep disorders, metabolic syndromes. So as we manage in the general population, same thing is to be done. The special things that you have to worry about is that you have to avoid valproate in the patients who are obese or who are turning obese or who are gaining weight. And topiramate and zonisamide are the drugs that are associated with weight loss. So these can be tried in the obese patients. Psychosocial comorbidities including stigma, social isolation, and unemployment. So every time the patient comes, don't just talk about the anti-seizure medicines. Talk about what is he doing? Is he going to school? Is he married? Is he considering employment? Has he been expelled from his job because of his current condition? So you have to ask all these things and try to find out solutions to this. You have to talk about all these things. You have to counsel them. You have to connect them to the support groups and vocational rehabilitation centers for the same. Now, cognitive comorbidities. Now, cognitive comorbidities may be the part of the epilepsy syndrome that the patient is having, or because of the residual seizure activity that is going on in the brain, and or it may be because of the anti-seizure medicines that the patient is taking. So it is good that we try to minimize polytherapy. If the patient can be managed with two drugs, we try them in the good dose rather than shifting to a third drug without using the first two drugs in the good dose. And we have to avoid the sedating anti-seizure medicines, as we have talked. Clobazam not to be given in the morning hours, to be given only in the evening hours. And we have to monitor the drug levels whenever it is indicated to see the patient is not having toxicity or high drug levels or high ammonia levels. Sometimes the like in valproate, it may be hyperammonemia, or in topiramate, it might be hyperammonemia, but you might get normal valproate levels. So ammonia is to be monitored in such patients, which might lead to cognitive comorbidity. Whenever you consult the patient, you address all the misconceptions and the stigma that nothing is going to happen if they are going to have leather slippers, sniffing of leather slippers. So all those things you have to ask them. These are very real scenarios that happen, for years they are just sniffing the slippers and not doing anything else. And even to my there is amazing things that literature is also publishing this. So there is a article where and the where it has been published that sniffing slipper is actually good for epilepsy patients. So I don't know what to interpret out of it, but even if such articles are published, those misconceptions should be avoided, and it is your duty that you tell them that these are not the true things. Then first aid of the seizures, you should also have, you may have in the soft copies, or in my OPD I have made a QR code. Every patient who comes, they scan that QR code and they have that. uh, they and their family should know what is to be done, what the positions are to be maintained when the patient is having first seizure, when the patient is having seizure or generalized seizures, what you have to do to avoid injuries, and how to use the inhalational agents like the nasal sprays of midazolam. So all those things should be guided to the patients, and maybe you can make a PDF, and then that can be shared in the language that the patient understands. Or if you are practicing in some clinic, you can make a video out of it, and then you can tell your patients that this is the link to that video, and they and their family can look into that. And even on international ILE website, there is patient information portal. You can just connect them to all those things, because it is very traumatic for the patients to have some disease, and during the time when they don't know what is to be done, it is very traumatic for them and their family. So it is our responsibility to tell them what is to be done. And then we have to tell them that they have to avoid the triggers. For example, if the patient is having seizures because they are not sleeping properly, you have to counsel them that during their exam times they cannot be not sleeping and then going to their exam to have seizure while they are writing their exam. So all those scenarios you have to tell them. And then you have to tell them compliance. 8 a.m 8 p.m means 8 a.m 8 p.m, doesn't mean that you can take medicine at any hour of the day. 8 hours of sleep means fixed 8 hours of sleep. It doesn't mean that you can one day sleep in the morning hours and the other day you can sleep in the night hours. And every time the patient comes, you check their medications, whether they are taking the same medications in the right dose. So sometimes the brand name may be different, sometimes they might be taking altogether a wrong medicine, or they might get a wrong dose outside and they are taking in a wrong dose. You have to discuss the side effects. You also have to counsel them against driving. So any patient in Indian scenario, if they have had seizure, they are not allowed to drive. And then you also have to address the social perspective like schooling, marriage, and travel. So the take home messages are that the accurate diagnosis is very important. We have to start with the monotherapy, and we have to assess the response and tolerability at each visit. You have to assess if the patient is or has turned into a drug resistant epilepsy. Among imaging, MRI is to be done for all the patient, and NCCT may suffice in the cases where, like Indian cases where endemic calcified lesions are very common. You have to screen and manage the comorbidities, and you have to counsel them according for their lifestyle, for their drug adherence, and for their education. And it is a multidisciplinary care. Not everything can be managed by just neurologist. We are in a team and we have to work together for a good life for these patients with epilepsy. Thank you so much.
Well, thank you, Dr. Jasmine, for a wonderful and very simple lecture that you have given, and I am sure those who have listened to it will be benefited by it, and there should be very less doubts for treating such patients now. I suppose so. But we have a couple of questions, although you have already addressed them. But I will just say, anti-seizure drugs useful in pregnancy protocol.
Hmm. Okay. So, when a patient who is, let us just consider a few scenarios. I have a patient who already has an epilepsy, and is taking anti-seizure medicines comes to me in the fourth month of her pregnancy, and she was maybe taking valproate or maybe taking carbamazepine. Her epilepsy is very well controlled. Now the patient has already passed that period where she was having organogenesis of the baby, and the epilepsy is very well controlled, so there is no point changing the medicines at this point of time. So she has already crossed that period. Now second scenario is the patient comes in that first 3 months, but the seizures are very well controlled. You have to discuss all the possibility of patients baby having congenital malformation if she continues to take the medicines that are likely to cause these abnormalities, that is valproate, carbamazepine. But then you also have to tell the chances are maybe less than 5% or something. But even she if she doesn't want to take any chance, and in fact we also don't want to take any chance, we make all attempts to change the medicines. So we make a shift, or we shift the medicines or we switch the medicines. But the switch has doesn't have to be on the same day. Like, you might have to taper down like 1 to 3 days, like, and the other drug, like if you're building up levetiracetam, that might take action in a few days, so maybe you can taper down this drug in a few days. Then the third scenario is that she comes in a preconception period. So she says that I'm going to plan pregnancy. Then you make all the attempts. You tell her that unless I change your drugs fully, you please don't get pregnant, and you can plan the pregnancy once I have fully shifted the drugs. In such cases, you go a little slow. If she is taking phenytoin, or if she taking carbamazepine, you bring down at one month, so that if the epilepsy is there, you do not disturb that, and you make her have seizures. So you bring it down by one month, and you add another drug, which may be lamotrigine, or it may be levetiracetam, which are the drugs of choice in epilepsy. So these are the drugs that you give to the patient.
Another query is what to do for calcified granuloma on CT, what to give, and if given, how to taper the anti-seizure drugs.
Okay. So first thing is that we are not going to do anything for the calcified granuloma. We are not treating the etiology in this case, because it is a calcified granuloma. It is going to stay there for life. We have to look at the clinical scenario of this patient. If the patient is having a focal epilepsy, you have whole range of anti-seizure medicines that you can give. Levetiracetam, carbamazepine, oxcarbazepine, clobazam, anything you can give. Clobazam not to be given as single drug, as an add-on drug only. So you have to depend on the clinical scenario. If this patient is not having a controlled epilepsy, like the epilepsy turns drug resistant, and in the pre-surgical evaluation I find that this calcified lesion is the one which is causing this drug resistant epilepsy, then I will refer the patient, or I will discuss with my epilepsy surgery team that we need to take out this calcified granuloma. So it doesn't need to be taken out for all the patient. Only if it is causing a drug resistant epilepsy, we need to take it out. Otherwise it is going to stay in patient's brain. You just have to tell them.
Is it necessary to increase the dose of anti-seizure drug if patient is responding well to its normal dose?
No, it's not needed. You start with the but then your drug should be in the therapeutic level. Sometimes we start with the levetiracetam 500 mg BD, and the patient is having seizures once in 3 years. But till now, to say that levetiracetam has worked, you cannot wait for another 3 years. So you will want to start anti-seizure medicine according to the weight based, like that it should be given on the weight based. It should be in the dose that is prescribed. It should not be less than that. So otherwise, if the patient is very well controlled, then you don't need to disturb it. Then you need to change the anti-seizure medicine only if the patient is having a new seizure uh, after a certain dose.
For breastfeeding, best option for anti-seizure medication.
Yes, so this is a question that I would say that I'm not very confident in answering, because though we prefer, we in pregnancy give levetiracetam, but then we also have seen that and read that levetiracetam has high excretion in pregnant in lactation, like in the breast milk it has. So there are chances that levetiracetam might go through the breast milk to the baby, but it has been seen that it is less likely to cause any side effects. So levetiracetam in itself is a very safe option. Other option is lamotrigine that we can give to such patient which has less excretion in breast milk.
For calcified granuloma, if no seizures but patient has chronic headache, then how to approach?
Okay, so you have to see a calcified granuloma. For a calcified granuloma to cause headache, there has to be some surrounding edema which is causing increased intracranial pressure. A small calcified granuloma, if you do a headache in patients with migraine who is having, uncontrolled migraine, you cannot attribute it to a calcified granuloma that you have incidentally found. So it depends on the clinical scenario. If the calcified granuloma is associated with some cystic lesion in the brain also, and it is causing edema, then you may say that the headache is because of it. Otherwise, maybe the calcified granuloma is just an incidental finding. Leave it. In fact, I tell my patients, if we get CT scan of all the neurologists who are working in AIMS, two of them will get calcified granuloma. So it is a common thing. You just get, for all the patients we get done for different etiologies, for different clinical scenarios other than epilepsy, calcified granulomas are a very common finding.
Well, there is another question on comment, basically ketogenic diet role in seizures.
Yeah, I did not cover that. So basically, ketogenic diet is also considered as another anti-seizure medicine, but it is to be tried in patients with drug-resistant epilepsy. It is not to be tried in patients with regular epilepsy. It is not recommended basically in drug-responsive epilepsies. But if you look at the literature, some literature might also try ketogenic diet, but it is a little difficult to implement. I'll tell you that the failure rate, not of the ketogenic diet, but on parts of the parents and the patients to follow the ketogenic diet is, that has more implications. It is just the fat that they have to take. It has to be prepared differently. So sometimes giving it once in a while, it might, it might go. But if you have to prepare a ketogenic diet all the three times in a day, it becomes a little difficult. But then we have patients and wonderful families of the patients who comply also for drug resistant epilepsy. It has to be given for drug resistant epilepsy patients. We have, if you want to read, we have a randomized control trial published from our center where ketogenic diet have been tried in drug resistant epilepsy compared to no ketogenic diet, and it has been found that in drug resistant epilepsy, if you try ketogenic diet, it has, those patients have a better response because it is just considered like another anti-seizure medicine.
Well, thank you then, Dr. Jasmine. I think it has been a wonderful session, wonderful interaction also. Lot many queries. People want to know more about epilepsy. So, but it is important to distinguish seizure, epilepsy, when to treat, how to manage, when to taper, and if at all to taper. Well, thank you, Dr. Jasmine, for a wonderful session. Thank you so much.
Thank
And thank
you.
you everybody for joining. We call it
Thank
a
you.
day. Thank you. Bye bye.
Thank you. Thank you so much. Bye
Thank you.
bye.